you took on the title of Chief Executive Officer, which was different from everybody else, and you maintained the Executive Director role. I'd like you to talk a little bit about what you saw, what you see as the role of a CEO, and maybe wrap that into what you would like to see as your legacy following your retirement.
Well, I think when I assumed the role, I knew that a very strong foundation had been built. And I think with the leadership of Victor Johnson and Don Rice and Reg Perkin, the time was right to be able to move forward even further, thanks to the work that had been done. Key to being able to do that was to continue with the strong core of the team that had been built, both at the staff level and the member level, and to have a vision for how we could continue to build that. I thought there was great opportunity to further augment our membership because there were so many who still did not belong to the college. There was a great opportunity to continue to build on, in particular, the strengths that had been developed within the academic family medicine environment by augmenting our organizational relationship with all of the other key stakeholders in academic family medicine, and a very important vista that had just begun to be explored by the college, and that was in the role of being a political voice and advocate more publicly on behalf of the college. When I started, the college had just released a green paper as a response to what was called the Behr-Stoddard report at the time, which had to do with physician resources and training positions, and there were many contentious issues at the time, but the college had actually stepped forward and taken a much more public position at that time. And as soon as I started, actually, and assumed the role from Reg Perkin, I was getting letters at the time from, mostly from, and it wasn't an enormous amount, but I'd have half a dozen or more letters from long-standing members that thought we should not be doing this. Those who thought we should do it, as is often the case, weren't sending letters, so you hear more from those who see it. And I respected their concern. They did not see the college as a body that should be getting into this, and yet the college board had made a decision that it did want us to start getting into it. So we spent some of the initial time when I became the executive director and CEO, exploring at a member committee level, board level, staff level, the pros and cons of where we were going. And it was a clear majority that felt that we had to be a stronger and more independent voice for expressing the needs of family physicians and the patients that family physicians serve, which again I think reinforced the value of us being an independent organization that could do this. So that was certainly something that I was very interested in terms of bringing all of our communities together. We developed a very important strategy with regard to our annual meeting, which I found to be something that became a priority for me because I did not think that the work and effort that we were putting into it at that time was getting the kind of reward at the end that it deserved. In terms, it was always an excellent meeting, but the attendance was around 500, 550 people in an organization with 10 to 12,000 members, and it was really, each year that I would go, I would see it was almost the same people in terms of the core who were already very involved in the college, and that's fine. It was a great meeting for them, and everybody learned. But if we were going to reach out to the masses out there, who were they? Where were they? Did they know us? Did they recognize us? Did they see us as a group that were not welcoming to them? And so we did some surveys of some of this. We had a very strong and still in its earlier phases section of teachers, which definitely had to be maintained as a strong core of our college, a new and potentially strong section of researchers. They were holding their own separate meeting at that time, and we had debates about whether we could bring these communities together by not symbolically suggesting we have one meeting for this group, one meeting for another, that we're all town and gown, and we're not really bringing everybody together as a community of family physicians. So we got approval to start what we then called Family Medicine Forum, which began in the year 2000. We doubled the attendance the first year to 1,000. We brought the section of teachers meeting and our researchers together with the clinical practice meeting, and it continued to grow from that point in time. I think in 2012, when my last year here in Toronto, we had something like 5,500 people or whatever at the meeting. Numbers are not the important thing. The meeting, the feedback we get about how dynamic this was and how people would leave feeling they understood they were part of a large and meaningful, relevant community. You tend to feel very isolated in your practice every day, even if you're in a big city. You just go to work and you do your thing and you face the problems you're facing. You think you're the only one that has these kinds of challenges on your plate. By getting together with and seeing that this is a large, dynamic, relevant community and issues that can be shared and talked out, both in terms of challenges in clinical practice and quality of care, as well as some of the things that are happening on the medical political side that family doctors need support for. So Family Medicine Forum became very important as a way of bringing the communities together. And I think it started to, because we notice in our attendees, we would always have a proportion that was a smaller proportion, but not insignificant, of non-members. And we would start to see that some of those people would actually join the college. And so it was significant as well. It was just one thing, but it was, and I think still is, a very important program that the college basically is responsible for in terms of being seen as the organization that is there for all the family physicians in the country, and having them have a chance to see that that actually is happening, that they are there with hundreds of others of their colleagues, meeting new people, meeting old friends, talking over things. I think it's critical. So we had an opportunity at that time when I started in this role to actually explore different strategies that would help us to become that more meaningful organization. Strategies that would build on what had been started as an independent, strong voice. When I first started, we would find that if we were trying to get heard and arrange visits that would be appropriate with government leaders at the federal level in Ottawa, and the National College is responsible for the federal and relationships with our college, while the chapters basically assume the lead role at the provincial territorial levels. We were often meeting with response like, well, you have to remind us who you are. So although inroads had been made, and we did find players who definitely knew who we were, there were still too many that didn't in other organizations and at key government levels. And so we had strategies put in place to start to address that, in terms of meeting the bureaucrats, in terms of putting out papers and making sure they got them and following up so that we could discuss them with them. It didn't always have to be in a face-to-face meeting, of broadening the base of our membership who actually would become involved in this and could actually advocate with people who were in key stakeholder positions and had relationships within that part of the country with people who were our members. So lots of things that we're doing this. We were very concerned about the fall off in student choice of family medicine, which really became a reality, not in so much in my first few years, but started probably within 3 or 4 years later than that, and continued right through into the first half of the decade from 2000 to 2005 or 6. There was a problem with physician resources in Canada, and we were part of the Canadian Medical Forum, which is the leaders of 9 or 10 national medical organizations, who made this physician resource challenge one of its priority issues. And we had, we co-chaired that. This was another sign that we were being recognized as equal in many ways to the CMA and the Royal College in particular. And several committees were set up with co-chairs from those 3 organizations. Previously, we might not have achieved that. And one of the big ones was how to address the physician resource shortage. And the area it was hitting the hardest was family medicine. And at the same time as it was hitting family medicine the hardest, it proved to be a deterrent to medical students to selecting family medicine as a career. Because all they were hearing and reading about was, we don't have enough family doctors. The ones who are left are so overwhelmed because they're trying to handle patients in their practice, and it's being suggested they should continue to take on more and more patients even though they can't handle the load they have because there is no one else to do this. This was not a healthy thing. So we had to address the physician resource issue, and we had to address the medical student issue in terms of reasons. And we, again, surveyed medical students, met with medical students, and there was a list of reasons why they were not seeing family medicine any longer as their number one choice. We hit a low of around 23 to 24%, choosing it as first choice in 2003, 2004, and we certainly hoped we were going to bottom out there. So we built a few things. We decided that medical students should have a greater role within our organization. We established a section of medical students, which we'd never had before. We had medical students' positions added to our board. We went around to medical schools across the country with the help of our chapter representatives and people in the academic departments, and we started to play a more active role. We established medical student and family medicine interest groups amongst the medical students in every school. We got some funding support both from the college and helped advocate for some government support in some provinces, and had medical students running these groups, and had family doctors in their communities meeting with medical students in the evenings and on weekends and showing them some of the things that happen in family practice, doing simple procedures that they do in their offices. Student feedback was incredible. They never knew family doctors did this stuff. They were learning that, you know, taking care of diabetics, taking care of people with congestive heart failure in their lectures and seminars and small groups, it was always other specialists that were the people who were identified as caring for those people. 85 to 90% of the population with these problems are cared for by family doctors without specialist referral. It's a smaller percentage, and we know this from all of the studies of the demography of medical care and healthcare in North America, that this is the case. The studies by Kerr White in the 50s and by Larry Green more recently. So we built on that and built a medical student presence and came back such that more recently we're back up to around 34-35% of students selecting family medicine first. So these were amongst the goals starting out that take time, and then there was the whole issue of needing to address the changing reality in practice. Yes, we will never have enough family doctors to take care of everybody in all of our communities alone. Everyone, we believe, should have a family doctor. The work by Starfield and Machinko and all their colleagues showing the value to population health outcomes of having a family physician is clear. That population health outcomes are definitely better in populations that have access to a personal family physician. But family physicians can't care for the whole spectrum of every problem only on their own in the most efficient or effective way. We respect our colleagues who still try to do that, and in some small communities, for sure, that may be the only thing that realistically can happen. But where it's possible, team-based care is where we're at. And so our college, again, through some debate that took place at committees and board levels, has reached the point, I hope, of a dedicated commitment and maturity in recognizing the value of a team-based approach, with family physicians still playing a key role with every person having a personal family physician, but not necessarily needing to see just that family physician for every problem. There can be nurses, nurse practitioners, physician assistants, physio and occupational therapists, clinical pharmacists, many others who can play a role on teams quite appropriately within a setting. Family doctors and colleague family physicians who have special interests. Family physicians and our Royal College specialty colleagues together in a patient's medical home, as we are calling it, in terms of our vision of what a practice could look like. And with the goals of that being measured by quality outcomes that we want to measure and follow. That's the future. And that's a future for the public of Canada and a future for family medicine and family physicians. And those that are getting into those kinds of practices, it's still early, but the feedback is very positive from the family physicians, from other healthcare professionals, and very importantly from patients who are part of practices like that. So these are all things that were early visions at the start of my time. We had a team that we put together of leaders, staff, members who were elected to positions, sat on committees, who shared these visions and did the nitty-gritty work that had to be done to be able to achieve those things, and many more that I'm not referring to, but those were some of the key things that happened during that 16 to 17 years.